And so really, when you're looking at somebody with depression, it's not like you can just say, this is what the archetypal person with depression looks like. It's very different across the board. Typically, I find that the agitated insomnia, higher energy depression is less common than the tired, fatigued, low energy type. But that's just in my clinical experience, and maybe if you worked in different settings, that might be different. So it is one of those conditions that's quite heterogeneous. Not sure if that answers your question. Yeah. Okay. Other questions? Okay.
If a person goes for a certain period of time without having a major depressive episode, is there a point where they can lose the diagnosis, or is it a lifelong thing?
So the question was, once somebody has an episode of major depression, is there a time period that elapses that they lose the diagnosis? And really what we would then say is it's in full remission, right? So that would be the specifier, full remission, once it meets criteria for that. But because it is cyclical, it's one of those things that once you have an episode of major depression, you should be aware of red flags, because if you can catch it early, you can possibly intervene early to not go down the route of a full-blown episode. Maybe you catch it and you catch your red flag is isolating, sleeping a lot, or having thoughts of worthlessness. Maybe you can catch it there. And so the idea is that at that point, you might have sort of those residual symptoms, and you can nip it in the bud before it becomes meets criteria for a full-blown depressive episode. But really, when we look at the statistics, we have to know that that person who has one episode is at very much an increased risk. And it's not like we become hyper-vigilant, looking for depression to raise its head, but we need to be smart about it. So that then we can intervene early, because we don't want that person to have repeated episodes, because remember that leads to a worse prognosis going forward. So does that answer your question? Yeah. You had a question? Okay. Yes, up the back. So in case you couldn't hear the question, so having an episode certainly puts you at greater risk for future episodes. The question is, does having an episode then put you at a greater risk for a more severe episode going forward? And I don't think that there's the precise statistics and research on that, at least that I'm aware of. Again, I think there's a lot of individual variability around that. Certainly, you can, once you've had an episode, if you approach that from a learning perspective, because actually before you relapse, you lapse, right? So there's a difference between lapsing into the negative thinking that goes along with an episode and relapsing into a full-blown episode. So if you actually learn and you get appropriate treatment in that first episode, it may be that you can actually reduce the severity by using what you learned that first time. That's why it takes people, on average about 5 times to quit smoking. And the people that do quit sort of use each of those attempts as learning opportunities, not failure. You're learning something about yourself each time. And so it really depends on so many individual factors really around depression. And some of it sort of feels almost out of your control, just like diabetes in a sense, but yet we can manage our diet, there's things we can do, and there's risk factors around that, like genetics that we'll talk about. But yeah, so much individual variability around that. And I think Also, what that suggests to us, though, in this profession as psychologists, when there's so much individual variability and it's not just 100% determined that this will be the course, this is how much genetics contributes, that actually suggests there's so much sort of wriggle room, so to speak, in terms of where we can intervene to really improve this disorder that is so incredibly disabling for the people that have it and also their families. Watching a loved one suffer with depression is horrendous. And so I think one of the key take-homes is, yes, there's a lot of individual variability. Yes, we can't precisely predict the pathway that somebody who's had one episode will go. And we know that there's a lot of factors that it can actually be protective and can buffer that person to try to change the course that they might be headed towards. Yes? So the question was around treatment in terms of there's our traditional medical model in terms of a lot of people that feel depressed will actually go to their GP. You know, it's not like they even see a specialist like a psychiatrist to prescribe psychiatric meds. It's the GP, your general practitioner, that is actually treating most people with depression. And, you know, there's something to be said about that. And if you recall, one of the primary limitations with a medication-focused approach, and we talked about this a couple of weeks ago, is it's a Band-Aid. It addresses the symptoms, but it doesn't address the underlying causes. And so that's why relapse is so high if people stop their medication within 3 months after the episode. And given that we know it's cyclical, that should also be a sign that really this person needs more than just a prescription of Prozac or other, you know, antidepressants that we'll talk about later today. And so we'll be touching on several evidence-based approaches, but certainly exercise is one of the best preventative things for depression. You know, it naturally releases endorphins and feel good. It naturally gives us a sense of purpose, a sense of mastery, increases our self-esteem. So certainly exercise and getting people active and living healthy lifestyles, reducing their alcohol intake if that's contributing to their depression, reducing their weight if the weight is contributing towards their depressive symptoms. You know, really a holistic, tailored approach is likely to have the best long-term outcomes rather than just putting a Band-Aid on the symptom with medications. But that said, medications definitely have their place in terms of management as well. So I don't want you to walk away from this saying anti-medication certainly has a place, and we need more of that holistic perspective as well in terms of treatment. And we'll talk more about that today too. Yes? So the question was, you know, if we live well, we eat well, we have good sleep hygiene, we exercise, we engage in self-care, can that prevent or cure depression in a way? And I think we need to be very, very careful around assuming that because there is a genetic contribution and there are life stresses that contribute, and as much as we all might like to control life stress, it has a habit of rearing its head again, right? And so with that, yes, there are certainly things we can do, and I think it's, you can see the pitfalls of saying it's all to do with people's lifestyle, because then you can fall into the pitfall of essentially blaming the depressed person for being depressed. Oh, it's their lifestyle. Yep. And not have any kind of understanding about that. And yet we know that lifestyle does contribute, and so we can do our best to manage that side of things. And if still, when we're doing our best, these episodes do come up, how do we best work with that to prevent it impacting going forward? And that's when, so then we can work on our self-care, our sleep hygiene, our exercise, our diet. All of those things are modifiable risk factors that we can work on. And it often helps to actually have a professional, a psychologist, to help us work on those things. Because if you have depression, what's one of your symptoms? Loss of motivation, loss of interest in engaging in activities, fatigued, loss of concentration. So all of those symptoms of depression actually suck our motivation to even do those things that we know would help us. And that's why, as psychologists, we actually put programs in place and we have structured treatments to actually re-engage people. Something like, we won't touch on this specifically in this course because we don't have time to get into all of the evidence-based treatments, but something like behavioural activation. If somebody's primary problem of depression is that they are fatigued, they're sitting on the couch, they're not engaging, they're not doing pleasurable activities, we can engage them in what's called a behavioural activation approach by Martel and gradually increase their engagement, knowing that then the reinforcement that they get from doing those pleasurable, meaningful mastery activities will actually reduce their symptoms. So I think it's a fine line between acknowledging that all of those factors contribute to depression and then using that to blame the person with depression to say, oh, it's your lifestyle or this or that, because there is a genetic heritable component to it as well that puts us at higher risk. There's the other modifiable stuff, but there is a genetic link as well, which we'll talk about too. Yeah. Does that answer your question? Yeah.